Welcome to this explainer. I'm absolutely thrilled you're here because today we're tearing down the walls between two worlds that, let's be honest, usually do not speak the same language: the fast-paced realm of tech and the incredibly complex world of medicine. We're looking at a brilliant course called Evidence-Based Medicine, or EBM for Techies. It's built specifically to help folks like us, engineers, data scientists, and technical pros, decode clinical data from first principles. If you've ever stared at a medical paper and felt completely lost in the dense terminology, well, this explainer is going to give you the exact mental models you need to make sense of the whole shebang. So, are you ready to start treating medical papers like an open-source code base? Let's do it.
Okay, let's dive into this. Here is our roadmap for today. We'll start with EBM built for techies, move into decoding clinical practice guidelines, explore how guidelines are built, and then look at spotting industry influence. After that, we'll hit the trial average dilemma and wrap up right where we should, starting with the patient.
First up, EBM built for techies, translating medicine for the skeptical techie. The absolute foundation of this entire approach is right here, starting with the patient, not a p-value. You know, when we as data-driven folks look at raw data, our immediate instinct is to just hunt for statistical significance, right? We're desperately looking for that magical p-value to tell us if a result is valid. But clinical cognition has to work in reverse. We literally have to anchor the data to the human stakes first. Before we even think about critically appraising medical literature or arguing over standard deviations, we have to ground ourselves in the very real, very messy reality of the person sitting in the exam room. Because at the end of the day, the math only matters if it meaningfully impacts that specific human life.
To do that, we kind of need a Rosetta Stone. In medicine, researchers talk endlessly about RCTs, or randomized controlled trials. But for us, we can just think of an RCT as a highly rigorous, large-scale A/B test. It's the same logic. And when clinicians talk about diagnostic accuracy using terms like likelihood ratios, we can map that directly to Bayesian updates. Think about it. You take a prior probability of a patient having a disease, you run a diagnostic test, and then you update your confidence based on that new data point. It's exactly the same thing. Suddenly, this opaque medical world isn't so foreign after all. It's really just a different flavor of the exact same probability structures we use every single day to build software and analyze user data.
Moving on to decoding clinical practice guidelines, zooming in on Lesson 7.
Now, clinical practice guidelines are essentially the rule books that doctors follow. They literally dictate the standard of care. But how do we, as skeptical techies, read them critically? Well, Lesson 7 breaks this down into 3 distinct pillars. First, building with grade, understanding the underlying framework used to construct them. Second, spotting industry influence. And third, reconciling these massive generalized guidelines with the highly specific individual patient. Let's unpack these one by one.
So how guidelines are built, unpacking the GRADE framework. Medical guidelines are built using a system called GRADE. Now, if you read a standard medical textbook, the definition of grade will absolutely put you straight to sleep with academic jargon, but this course translates it brilliantly for our brains. Think of the clinical evidence as your test coverage. How robust is the underlying data? How many edge cases did the trial test? Was the methodology sound? Then think of the ultimate clinical recommendation as the ship decision. Are we deploying this to production? Imagine a scenario where a new intervention lowers blood pressure. Awesome test coverage, right? The trial was massive. But what if the side effect profile includes severe, debilitating fatigue for 50% of users? Well, the test coverage might be high, but the ship decision becomes a definitive no-go. So GRADE is really just a logical, structured framework for evaluating how much we actually trust our data before deploying a recommendation that affects human lives.
Next up, spotting industry influence, finding the bias.
This brings us to a really vital question. Who is influencing the data? The EBM course incorporates this awesome interactive AI called Vibrance. It uses Socratic learning, which means it's deliberately designed to question you and challenge your assumptions rather than just handing you the answers on a silver platter. It literally forces you to pause and critically interrogate the source of the clinical numbers you're reading. When you see a highly publicized guideline strongly recommending a shiny, very expensive new drug, you've got to ask, who actually funded those trials? Who wrote the guideline? Were the negative trials quietly suppressed while only the positive ones saw the light of day?
Because, let's be real, guidelines are not built in a vacuum. They're created in a remarkably complex ecosystem involving pharma companies, financial incentives, organizational pressures, and just simple human bias. A core competency here is learning how to stress test the validity of these clinical recommendations by actively sniffing out those external pressures. It's about taking off the rose-colored glasses. You want to view medical data with the exact same healthy skepticism of a senior engineer auditing third-party code before integrating it into a core system. You don't necessarily assume malice, but you absolutely verify the architecture.
Which leads us to the trial average dilemma, data versus reality. Here's where the math gets really fascinating. Clinical guidelines are based on massive trials of thousands of people, which gives us a very neat, aggregated trial average. It tells us what happens to a broad population as a whole. But on the exact opposite side of the equation, we have the individual patient. This is the messy, totally unique, complex reality of a human being sitting in a clinic who might not fit that statistical mold at all. I mean, what happens when a guideline strongly recommends a treatment based on an average 50-year-old male with 0 pre-existing conditions, but the patient in front of you is a 75-year-old female taking 3 other medications? This friction between the aggregate data and the individual reality is honestly the hardest part of evidence-based medicine.
And this brings us to a massive aha moment. In the media, or even in the executive summary of a guideline, you might read a headline celebrating a massive 40% risk reduction from a new treatment. Sounds incredible, right? Like a total miracle cure. But as the course points out, that is often a relative risk reduction. When you pull back the curtain and actually work out the absolute math by hand, you discover something called the number needed to treat, or NNT. That same 40% relative risk reduction can easily translate to an absolute reality where you have to treat 25 people just to help one single patient. Yep, an NNT of 25 means the other 24 people get 0 benefit from the intervention and might only be subjected to the side effects and the financial cost. It completely proves why you cannot blindly accept a top-line summary. You have got to do the math to understand the actual clinical impact.
Finally, let's look at starting with the patient, tying it all together.
This workflow maps directly to Lesson 9 of the course, where we take a real, de-identified patient case from end to end. We kick things off with Step 1, the patient, looking at their unique history, symptoms, and personal values. Then, Step 2, the evidence. We formulate our specific clinical question, build a search to find the data, and critically appraise the trials and guidelines using everything we just talked about. We're checking the grade framework, assessing the test coverage, and looking for that industry influence. And finally, Step 3, the decision. This perfectly illustrates that rigid data and broad population guidelines must ultimately be filtered back down through the highly specific context of the individual patient. The data informs the decision, for sure, but it does not dictate it.
And that leaves us with a final, pretty provocative question to consider. How will you stress test the data in your own life? We are constantly bombarded with health claims, flashy statistics, and rigid medical recommendations. But by adopting the mindset of a skeptical techie, by treating randomized trials like A/B tests, by understanding test coverage versus ship decisions, and by always anchoring back to the individual instead of just the population average, you now have a framework to actually decode the noise. The next time you encounter a medical statistic, don't just blindly accept the p-value. Question the source. Look out for the trial average dilemma. Uncover the number needed to treat, and find the real human stakes. Thank you so much for joining me on this explainer, and remember, keep questioning everything.